Yes, good evening, one and all. It's a pleasure to coordinate the proceedings of today's lecture. I was always on the other side when this lecture series started. Now I'm on the other side where I'm conducting this. Thank you, first of all, Rashmin sir, for giving me this opportunity. So on the behalf of the organizing team, Team DY Patil, I would like to welcome all the respected faculty members for today's lecture and all the participants. It's my privilege to introduce our chairperson for the day today, Dr. Ashutosh Shah sir, uh, who will be the moderator for the lecture today, Psychopharmacology, the actual pharmacology in the psychopharmacology, beyond drug levels and half-lives. And we have no other better speaker for the topic, that is Dr. Bhaskar Mukherjee sir. He needs no introduction, everybody knows him well. Dr. Ashutosh Shah, who will be the chairperson for today's lecture series. He is a consultant psychiatrist at Sir H.N. Reliance Foundation Hospital. He is having an experience of 25 years. His special areas of interest are mood disorders, schizophrenia, and dementia. Over to you, sir, for further proceedings.
So thank you, Dr. Vispute. I believe that we can do away with the introductions, rather go straight into the topic. And for a brief recap, so last year, that's last month, Dr. Bhaskar had explained about how the psychopharmacology or in general pharmacology starts with not a passive process in the gut, but an active process. And there can be several mutations at the receptors in the gut itself. Subsequently, after getting absorbed, the free fraction of the drug or even the protein bound fraction can vary even in illness and many other conditions like inflammation. After that, when the blood-brain barrier has to be crossed, again, that's an active process. And the drug level in the blood, CSF, is not a good indicator, actually the brain concentration. And then at the receptor level, the receptor getting internalized, triggering all the subsequent second messenger pathways, acting on the nucleus, triggering the transcription processes. Then either the receptor is reabsorbed the neurotransmitter is reabsorbed or it is metabolized, and there can be many mutations over there. Finally, the excretion, three-stage excretions, one in the liver with the cytochrome, which most of us know, and then several others also present. So there are too many variables which may explain why one molecule works for an individual and the same molecule may not work for the same individual at a different stage, or when that person has a medical illness or has inflammation, etc. And then finally, Dr. Bhaskar gave what the future studies may be, would be to have studies to show the effect of the drug at the molecular level, at the circuit level, at the network level. And that would be much more meaningful to have personalized medicine. So I hope, Dr. Bhaskar, this was an accurate summary of whatever that I remember from the first session. You may feel free to write me over here itself.
I would say mostly correct, but one thing is what I have stressed in last lecture is neurotransmitters don't do anything.
Exactly. So
that part should be dead.
So the theory about neurotransmitter deficiency or excess is outdated. There is not enough evidence to support it. Rather, the second messenger and the receptor not working, etc. Those will be the areas which will be explored further. And today, I believe Dr. Bhaskar is going to talk about individual drugs in details for the audience. So the platform is all yours, Dr. Bhaskar. Thank you. And I'll come back at the end.
Okay. First, let me give you something. If I start with individual drug, then this lecture would continue till end of this year and even beyond that. Because each of the drugs are actually more than a lecture unto themselves. There is no drug group called SSRI because last lecture I have shown that serotonin doesn't do anything, There is no drug group called DNRI or SNRI or the name that we use on them, antipsychotic and other thing. So standing there, we today would explore what this drug generally do, how they do it, and we would get an overview. Don't even think it as a psychopharmacology 2-week course. Rather, it would be 2 days overview of the complexities of psychopharmacology, just to make you understand that most of the teachers of current era and most of the romantics of current era say psychiatrists know psychopharmacology enough, they don't know psychotherapy. While the actual reality is different. Psychiatrists know nothing about pharmacotherapy and they are romanticizing about psychotherapy. This is the only thing that I can show, because otherwise, psychopharmacology is such a big thing. It takes few lifetimes to understand it. With these ominous words, I would start my presentation. I am turning my video off. So today we are going to talk about pharmacodynamic as well as systemic architecture of psychotropic agent. How they work, where they work, and how we can conceptualize it. Last talk we have seen that the neurotransmitters are mostly nothing, and so monoamine hypothesis doesn't stand at all. Although they have dominated psychiatry for over 70 years, it is time for us to bid fond farewell to monoamine theory, and along with that, the names that monoamines generate. Antipsychotic doesn't exist, because what is psychosis? Beyond DSM classification, nobody knows. Antidepressants, that same thing. Beyond DSM make-believe diagnosis of depression, these drugs do a lot of things, and make-believe diagnosis of DSM depression doesn't exist. Mood stabilizer is another of such funny name, because there is no voltage. So mood stabilizer should not be a perfect word for it. So what would be the reality? The reality would be these are dirty drugs, and they work in multiple pathways, multiple areas, and almost a huge part of G protein coupled receptors and intercellular signaling, epigenetic machinery, mitochondrial bioenergetics, microbiome, everything is involved in their action. And why it is now the perfect time to talk about these things? Because that many of the dogmas at present doesn't have much validity. The traditional dogma of schizophrenia and bipolar are different is slowly going away. A BSNP study and various other studies have shown that. Then various genetic data shows that almost 60 to 80% of psychiatric name has same genetics. Then the natural evolution is driven by mostly common genetic variant which are shared, and drugs doesn't care about DSM or ICD. Which drug work in psychosis should also work in mania and vice versa. Similarly, drugs which work in epilepsy would also work in impulsivity and various other things. Then the pathways are also very much overlapped. So here I would try to show is what is molecular psychopharmacology, how does that work, what are the systemic footprints of a drug, how they modulate mitochondria, lysosome, cell, various cell organella, gut-brain axis, and other things. What are the epigenetic effects that our drugs are doing, and reimagining the drugs into something else. For example, many of our drugs can be effective anti-cancer drug. Many of our drugs can be effective anti-infective drugs and things like that. And this would be part of the talk. Antipsychotics started with theoretical dopamine blockage, D2 blockage, and that gave rise to dopamine hypothesis of schizophrenia. Unfortunately, now antipsychotics has evolved much more than dopamine blocker and things like that. They work in multiple other areas. Various other receptors are modulated by them. Not only dopamine, they actually work in glutamate, they work in neuropeptides, they work in neuronal various adhesion molecule, they work in various glial cell and their function, and ultimately they have a lot of things that was not covered in monoamine hypothesis. This was an old name that there is serotonin dopamine antagonism, but unfortunately, atypicality is not conferred by only serotonin and dopamine ratio. If, as I talked about in last uh, lecture, if a drug gets attached too slowly or too fast, if a drug is just rapidly dissociating, if a drug is working as a positive allosteric modulator, or if a drug is working as inverse agonist, then too that would confer atypicality. So atypicality means high serotonergic blockage compared to the D2 blockage is at this moment not really scientifically valid. This is a comparative receptor binding affinity. This is from typical textbooks. So we are showing this table based on the receptor hypothesis and receptor binding that people are comfortable with. This is neither the real picture nor it is the all-encompassing picture. Haloperidol is typical because it has high D2 affinity. Cariprazine has less, almost greater, and aripiprazole has also greater D2 affinity. But they are partial agonists, so they are atypicals. Then haloperidol has very high serotonergic concentration to block various serotonergic receptors. So haloperidol's affinity to all the serotonergic receptors is very low. Conversely, clozapine, olanzapine, risperidone, they have much more serotonergic receptor affinity. Some of them have 5-2A affinity. Some of them has 5-1A affinity more than others, and some of them has 5-2C affinity more than others. Clozapine also have D4 affinity, H1 affinity, M1 affinity, alpha 1 affinity, alpha 2 affinity, all of which are moderately strong. Along with that, olanzapine, which is the synthetic drug which was supposed to be less toxic than clozapine, but again, a drug like clozapine has different binding profile to this receptor, unlike clozapine. Olanzapine affects 5-HT2C, D1, D3, D4, H1, M1, alpha 1, and alpha 2 less. So we can see that all these have various receptor affinities. None of them work directly on D2. And so by dividing these into typical and atypical, we are not really doing much help in our understanding. Clozapine, olanzapine, and quetiapine, as well as asenapine, the pints, they are so-called broad spectrum. Why they are broad spectrum? Because they affect a lot of receptors. But the receptors I have shown here, are they all? No, they are not all. Here comes the difficult things. Here, after alpha 2, clozapine binds on a lot of other molecules, including ion channels. Olanzapine binds to a lot of molecules, including various neuropeptide, and quetiapine also probably binds to the neuropeptide responsible for sleep-wake cycle. Risperidone, ziprasidone, and lurasidone, they are thought to be potent D2 as well as 5-HT2A antagonists. But risperidone, along with that, also blocks various notch receptor as well as notch intracellular domain in neuronal as well as bone stem cell. Ziprasidone and lurasidone also have the same level of action. Now come partial agonists. Here, aripiprazole was told to be a kind of antipsychotic that would be partial agonist to D2. And it was thought that it is going to stabilize the dopamine system by not blocking the internal activation completely. Unfortunately, in contrast to these action 1, 2, and 3, aripiprazole has its own unique action. This was the idea. But when aripiprazole came with its own unique effects because aripiprazole went and became something more. It started affecting the various autonomic receptors and it worked as a autonomic stimulator. So what happened with aripiprazole? Aripiprazole made most people show some form of akathisia, specifically people who are very sensitive to antipsychotic action. So although partial agonists were thought to be something that would cause change in how dopamine transmission occurs and how the side effects occurs, partial agonists in their own right became another form of dirty drug. Now cariprazine, the billion-dollar drug of USA, which doesn't even touch million-dollar sale in India and also Southeast Asia. The main question is why? Why cariprazine, the billion-dollar molecule, is not working in India? That I would give some hints about. But first, let's talk about the thing that is marketed about cariprazine is true or not. Cariprazine is told as D3 preferring agent. Cariprazine shows significant higher affinity for D3. Now, it was thought that D3 receptors are concentrated in ventral striatum and nucleus accumbens. So, motivation, reward, and mood regulation would be affected by cariprazine, and cariprazine by binding with D3 receptor should improve negative symptom and low mood. What is the reality? The reality is cariprazine is almost same as aripiprazole. It is a drug which causes autonomic hypertension and hyperactivity. It has good affinity for D2 and many patients develop D2 related side effects, and aripiprazole and its unreliability touches cariprazine too. As in India, we don't go by a guideline much rather with our clinical experience. This is why cariprazine hasn't been successful in India. Now, brexpiprazole. Another molecule that is thought to have less dopamine activation than aripiprazole. It has higher serotonin affinity, and it is thought to be a balanced profile drug. Unfortunately, its efficacy is not at all high. That makes these theoretized action again a question mark. I was clear from the very start that I would show drugs, talk about them something, try to break down the misconceptions, but it is impossible for me to talk about every drug in detail. Then we are not going to have anything, any time today. Now, TAR agonism. The post D2 era. Finally, some people thought that there is enough harping of D2. Now let's go to something else. TAR is trace amino acid amine receptor 1. There are multiple variety of these receptor, type 1, type 2, type 3, and we are understanding more and more of these receptor. These are receptors which work in pacemaker activation in brain. These are receptors which work in neuronal excitation, and by affecting these channels, it was thought that it would help in increasing the negative symptom, decreasing the negative symptom, as well as increasing the cognition and emotional deficit in psychiatry, in the treatment of schizophrenia. Problem of glutorant and the hype around glutorant is we are forgetting clozapine has TAR1 agonism. Olanzapine has TAR1 agonism. Quetiapine probably has TAR1 agonism. There are multiple so-called first generation antipsychotic which have TAR1 agonism. They didn't change much. So, glutorant, another drug that pharma is trying to push, would not be a very good drug for psychosis. This is the theoretical. This is the theoretical, I am saying. This is not practical. TAR1 activation followed by reduced hyperdopaminergia, followed by presynaptic modulation of TAR activation, and that it is thought to preserve dynamics. Unfortunately, all these are already done by multiple antipsychotic that came before. But nothing changed because our basic understanding is at fault. Now, xanomeline tropsoupium, Cobenfy, the future blockbuster molecule of psychosis. And I am expecting it to be a dud in India, as well as in other countries of Southeast Asia, where we don't do guideline-based practice. Because neither M4 receptor modulation, neither M1 receptor modulation would change much cognition in patients with chronic psychosis until and unless we start adding other drugs to it. Other drugs might be antidepressant, so-called, might be glutaminergic modulator like memantine, which would be that is very hard to describe because each of these people have different genetics guiding their natural evolution of disease. Now, the already failed molecule in India. I don't know how many of you have written lumateperone. Being a early adapter, I generally write every molecule when it launches, and I try to write it in maximum dose, supramaximal dose, low dose, in all of the possible application. Lumateperone is one drug that literally, I would say, sucker punched me because I didn't expect it to be a very good drug, but I at least expected it to work something. This is the first drug that didn't work at all. No work. This is the first drug after my MD for which I don't know where to write because nothing works. Double dose doesn't work. Single dose doesn't work. Half dose doesn't work. Mixing and matching with a lot of things doesn't work. This is a molecule that again shows all these M2R pathway, NMDA, hyperfunction, high selectivity. They are theoretical, very good to hear, but practically ineffective. Now, pimavanserin. Pimavanserin is something which works, but probably not via serotonergic property. 5-HT2A receptor inverse agonist and 5-HT2 receptor inverse agonist. It works in various old age psychosis, not only in Parkinsonian psychosis, although that is the approval, but you can jolly well use it as a drug like olanzapine in most situations if you consider it as very low dose olanzapine. Now, I would like to draw your attention to the fact that why I am saying the reported mechanism of action is wrong. 5-HT2C inverse agonist, antagonist, whatever that might be, drugs which has this capacity has two things in common. Sleep, increased appetite. Pimavanserin doesn't show this consistently. So, again, it works, but the way it works is not the way it is marketed. So I have shown via multiple medications that theories doesn't work. The theoretical mechanism, starting from haloperidol to pimavanserin, that doesn't work. So what works and how that works? Receptor binding is merely the initial effect. After the initial effect, the real effect starts. After receptor binding, these molecules change various kinase pathway, protein kinase A and CAMP pathway, then AKT GSK3B pathway, and protein kinase C pathway. Yes, endoxifen and tamoxifen is not the only protein kinase C blocker or agonist. There are multiple psychotropic who do the same, but endoxifen and tamoxifen is only doing that. Beside other drugs are doing it beside other things. Then comes M2RC modulation and P53 modulation and P72 modulation. And there is immediate early gene manipulation. Acute administration induces CFOS, ARC, EGRL expression, and serves as a transcriptional fingerprint in clozapine and haloperidol does it in nucleus accumbens as well as dorsal striatum. Chlorpromazine also does it, but in a different area. Now the lithium. Lithium is probably the best example of the versatility of psychotropics. Lithium enters cell through voltage-gated sodium channels and interact with magnesium-dependent enzymes. Lithium works via GSK3B inhibition, inositol depletion, but these two are initially known pillars. Lithium also does a lot of things in various other pathways. After GSK3B inhibition, there is inhibition of beta-catenin destruction complex, resulting in rescued beta-catenin and increased beta-catenin, causing nuclear translocation of beta-catenin and TCF, LEF activation, which ultimately promote neurotropic and neuroplasticity gene. Neuroplasticity gene means that these genes increases cellular stress handling power. And neurotropic gene means these are the genes which increases cell enlargement, cell life prolongation, and along with that, neural growth genes. GSK3B is a apoptotic enzyme, and it causes the apoptosis by phosphorylating p53 and backs. Lithium, by blocking GSK3B, increases p53 activity, and thus neuronal survival against excitotoxicity and oxidative stress increases. GSK3B phosphorylate clock genes, specifically part 2, regulating stability and nuclear entry. Lithium lengthens the circadian rhythm and ultimately helps in regularizing the disturbed rhythm, not only in bipolar disorder, but also in depression, also in psychosis with seasonal trigger. The inositol depression hypothesis is already over-talked, but there are multiple nuances. Anyway, that doesn't end lithium function. Lithium increases various growth factor action, nerve growth factor, epidermal growth factor, brain-derived nerve growth factor. Then, along with that, platelet-derived growth factor. All of them are upregulated, more secreted more, and their action is enhanced. As well as the action of BCL2 is also enhanced, and this happens mostly in hippocampus and frontal cortex, the two areas which is targeted by most of the excitotoxic damage. There is MRI mega-analysis consortium known as Enigma Consortium. They confirm that lithium treatment increases gray matter volume in hippocampus and thalamus plus amygdala volume. And thus, it causes reversal of the bipolar process induced, or rather excitotoxicity process induced neurodegeneration. Now, the transcriptomic signatures of lithium are now actually becoming more and more clear. Lithium downregulates the pro-inflammatory marker. Lithium upregulates the oxidative stress response marker as well as the protective gene. And lithium causes systemic anti-inflammatory effect. But with a catch. Lithium's systemic anti-inflammatory effect comes after an initial period of increased pro-inflammatory marker. This is the reason lithium sometimes exacerbate the DRESS syndrome, or lithium sometimes exacerbate acne. Lithium sometimes exacerbate psoriasis and other things. Because initially lithium is stimulant for inflammatory system, immune system, growth system. Rather, after late stay in body, body gets habituated to the presence of lithium and the growth response gets attuned to a higher baseline. And from that higher baseline, it is hard to disrupt that response. Lithium has antiviral property. We know about that and we have talked about it. Now, the anticonvulsant. Mood stabilizer, I never liked the word, and thankfully, I don't have to talk about mood stabilizer now because mood is not a voltage, it doesn't need stabilization, and CanMed guideline has already made it amply clear. Valproate, carbamazepine, lamotrigine, and all other anti-epileptic has distinct molecular mechanism converging on neuronal excitability, stability, as well as neuroprotection. And they significantly differ from lithium as well as one another. Valproate is mostly epigenetic remodeler. Valproate inhibits HDAC. Valproate increases histone acetylation. Valproate causes opening of chromatin state. Along with valproate, this same thing is also done by few antidepressant. Then it attenuates the arachidonic acid turnover and that reduces inflammatory signaling. There is also blockage of sodium, voltage gated sodium channels. In oncology, valproate is rapidly coming up as a new agent because in presence of valproate, chemotherapy and radiotherapy both works much better. So valproate is a good chemosensitizer as well as radiosensitizer. Carbamazepine was thought as sodium channel blocker, but now it is also known as this is adenosine receptor antagonist. And being adenosine receptor antagonist, it has effect on multiple unique epilepsies. For example, there is a channelopathy which affect HCN channel, the funny current channel. Carbamazepine is one of the drugs beside lamotrigine which works there because of this adenosine receptor blockage. Lamotrigine is thought to be glutamate modulator. But possibly the sodium channel blockage, high voltage calcium channel blockage, and various other ion channel mechanism is more important for lamotrigine than glutamate modulator. And the effect that is described by people that lamotrigine is antidepressant is never really right because lamotrigine doesn't increases neuronal excitation. Lamotrigine decreases neuronal excitation. So lamotrigine can reduce excitotoxicity, but lamotrigine cannot help in low mood. So you would ask why we are prescribing lamotrigine and we are seeing that lamotrigine helps in depression. Number one, cognitive bias. We know that lamotrigine is recommended for depression. So we are giving it. Many a time natural recovery is occurring and we associate with it. Number two, lamotrigine being a excitotoxicity dampener it reduces the repetitive excitotoxicity damage. That actually also help in impulsive compulsive behavior and makes the patient better. That also would appear to us as lamotrigine antidepressants property. If there are senior people here, they would remember at one time they used to prescribe valproate as antidepressant and they used to swear by it. Now, let's drag the name psychotropic into crucial critique. And here we will show that nothing is working on psyche and their mechanism is much, much different. Anyway, I have always said that antipsychotics are better at low dose, and if we are continuing, we should continue at low dose. This is the cause of that statement. Antipsychotics are mitochondrial toxins. They block mitochondrial electron transport chain. They specifically target complex 1, and complex 1 inhibition leads to a lot of problems in cell. Reduce ATP production, reduce work in various cytoarchitecture, reduce actomycin complex formation, increased ROS generation, and so antipsychotics in long term has a tendency to cause or rather enhance neurodegeneration. Now, many antipsychotics also get concentrated in lysosome, and this lysosomal trapping actually increases the drug concentration in liposome up to 1000 times higher than in plasma. And this high concentration helps in disrupting the cellular environment more. After accumulation in lysosome, there is neutralization of lysosome pH. There is no degradation of SREBP transcription factor, and active SREBP upregulates lipid synthesis gene, causing hepatostasis, steatosis, and systemic dyslipidemia. This is probably one of the mechanistic link between cellular pharmacodynamic and pharmacokinetic as well as metabolic side effect. Now, gut microbiome and gut-brain axis. I am not going into details of it, just an overview. most antipsychotics are potent antimicrobial and they causes gut dysbiosis. Now comes the drug repurposing, which our drugs are ripe for because our drugs are dirty drugs. They have multiple effect, multiple off-target effect, and that makes them ideal candidate for repurposing. In oncology, for glioblastoma, a lot of antipsychotics and antiepileptic are actively researched. Duloxetine, valproate, chlorpromazine, flufenazine, haloperidol, pimozide, penfluridol all have shown effect either preclinically or early clinically in glioblastoma. In antimicrobial resistance, specifically the MDR variety, our drugs work as helper compound by inhibiting bacterial efflux pump as well as by inhibiting various cellular action inside bacteria. So they act as good as sulbactam or even more. Now, problem is the name. With so many things happening, the name of antidepressant, antipsychotic, anti-epileptic comes in a very big question. But what can we do? Do you have any way to change the name? Because drug don't respect any diagnostic boundaries, and they should not, because these are artificial boundaries. ARDOC tried, but ARDOC ultimately is a dart. ARDOC is not going to help us. Similarly, neuroscience-based nomenclature, it was launched with very high fanfare, but it failed because it just replaced antidepressant with same wrong name as SSRI and things like that. This lecture and previous lecture has shown that there is no SSRI. Two SSRIs are as different as is possible. So here we come to the end. We have seen that a lot of things can be said about our drugs, and I just tried to give a bird's eye view, omitting a lot of things and mentioning very few things, because I don't know how to cram a whole year 365 into 24 into 60-second thing in 1 hour. So I have taken few areas, expanded it, but left major of areas. So we have to go back to our chalkboard and start thinking. We have to understand that our drugs are not only symptomatic drugs, they are changing brain at a very fundamental level, and they are actually disease modifying drugs. And DSM has to go. We have to adopt a dimensional approach. Personalized treatment is going to be mainstream. And here we would take digital biomarker as well as body-wise biomarker as well as genetics and pharmacodynamics. Then systems biological approach is the most promising approach towards psychopharmacology. This is the clinical implication of my rather boring talk. Boring because it cannot be helped. The research priorities would be biomarker development, pharmacogenomics, not genetics. We have currently pharmacogenetic tests which are worthless. Neuroimaging, microbiome studies, novel target, and things like that. So this ends my lecture. Rather boring, rather tiring, rather long, rather very complex. But psychopharmacology is not easy. Psychopharmacology is a very complex subject. If I study and research psychopharmacology for rest of my life, then I would need around 3 lives of 90 years to say confidently that I know something about psychopharmacology. It is that much vast. And unfortunately, all over the world, psychiatrists think that they know pharmacology and they don't know psychology. That is the biggest farce of all. Because psychopharmacology is almost unknown by us. With this, I am ending my lecture. This time, I hope there was no voice break or things like that.
No, thank you so much for taking care of that. I had excellent presentation, first of all. I mean, very detailed for each of the molecules. I had asked...
Very less, because if I go on talking about each molecule, it would take whole year.
Yes. Anybody? Any questions, please? We just have...
We have lost most of the...
Yes, we just have 3 or 4 participants just now. No questions. Okay, maybe Dr. Bhaskar, you are kind of spared from the questions by the audience just now.
That is actually a bad omen. That means I have missed them.
Okay. So anyway, thanks a lot for this wonderful insights that you have given today. Dr. Chetan, would you like to conclude?
Yes, sir. Definitely a lot of things to unlearn and new things to learn, as usual, when we listen to Dr. Bhaskar Mukherjee, sir. And yes, there is a need of paradigm shift. Definitely, when we define the role or when we classify, yes, surely it will happen over the time. And I would definitely agree with sir. Yes, it's a huge subject, psychopharmacology, and the learning will never end. But yes, we are having this lecture series and all esteemed speakers like you who help us simplify the complex topic. Yes, indeed, it's a very complex topic, psychopharmacology and understanding the action at the molecular level and the second messenger pathway levels. But yes, from the bottom of my heart, yes, I would like to thank today, and we are here at the end of the session. On behalf of the organizing team, I extend my sincere thanks to our esteemed chairperson today, Dr. Ashutosh Shah sir, who has guided over the session, guided the session very well. I also express my heartfelt gratitude to our speaker, Dr. Bhaskar Mukherjee sir, for simplifying the topic and enlightening us on the subject. My all sincere thanks to all the participants who have participated today and had a patient listening during this difficult. Thank you again. Thank you, Sun Pharma, for their unconditional educational grant. And see you soon every first Thursday of every month with some new topics and new speakers to help us learn the psychiatry. Thank you.